Hey, good evening, everybody. This will be a remarkably similar talk. Anyway, my name is Brian Sparkman. I am the second year CGSO fellow at Virginia Commonwealth University, and we will be talking about robotic cytoreductive surgery and HIPAC. We have no disclosures, and we'd like to thank SAGES for the opportunity to present. Cytoreductive surgery is really just the bulking of peritoneal surface malignancy, and the real goal is to get down to no macro disease that you can see. And the whole point of the HIPAC is to kind of kill any tumor cells that are left over at the microscopic level. We gauge what the disease burden is by the peritoneal cancer index, which is ranged from 0 to 39. It's scored depending on different areas of the abdomen and small bowel. And then we gauge our completeness of cytoreduction on a scale of 0 to 3, with the goal to always achieve a complete cytoreduction of 0. Prior to selection for cytoreduction and HIPAC, we always must weigh the patient factors to see if they're safe to undergo the operation. Age, performance status, they must be ECOG 0 or 1. Patient preference, this is a rather aggressive surgery, so you do need to make sure that the patient understands the risk going in. And really, the main question from an operative standpoint is, what's the likelihood that you can achieve a complete cytoreduction? Because there is several years of data showing that if you do not achieve a complete cytoreduction, there's no point in proceeding with the HIPAC. And again, we do want our patients to be an ECOG 0 or 1 prior to proceeding with this surgery. And this is a pretty awful surgery. I mean, when you compare cytoreduction HIPAC to other major oncologic operations, we see that the complication rates are about the same, with the one exception being mortality, which is higher in the cytoreduction HIPAC group. And there are some limited studies that look at laparoscopic as compared to open HIPAC to see if there might be some advantages to doing these with minimally invasive approach. However, a lot of these studies really only look at pseudomyxoma peritonei from low-grade appendiceal mucinous neoplasia, and the PCI is generally less than 10, which generally indicates lower disease burden. The proposed benefits are a reduction in blood loss and decreased transfusion requirement, which is extremely important. Also, shorter length of stay, improved wound healing, or fewer wound infections, and then you also maintain the oncologic significance of the operation. The reason that lower transfusion is important, there is a direct correlation between if a patient receives a blood transfusion and mortality for peritoneal surface malignancy. So the more blood transfusions that a patient receives around their perioperative period, the more likely they are to have a poor outcome. Looking at the larger laparoscopic series, we show that the PCI for these groups is generally less than 4 for the major series, and the length of stay is shorter than traditional open HIPAC, which again is typically around 10 to 15 days, but they did show a shorter length of stay. So our question was, well, what about robotics? Is there an advantage to using the robot platform? Will we have similar outcomes to laparoscopic surgery? Are there benefits over open? Will we have the ability to pursue higher PCI cases? And this is really the main question, because the whole goal here is to provide a better oncologic outcome for our patients. And then can we attack a larger variety of peritoneal surface malignancies, not just lamins? So our hypothesis was that patients that are undergoing robotic-assisted cytoreduction HIPAC would have a decreased blood loss and similar completeness of cytoreduction with a decreased morbidity compared to patients that have undergone open cytoreduction HIPAC for the same disease process and same PCI. We performed a retrospective chart review for over 6 years. This is updated from our abstract. We extended it out from February of 23 to December. Our inclusion criteria were any patients that underwent cytoreduction HIPAC at our institution. Ages included were 18 to 89, and again, this was a single institutional study. We looked at demographic data, intraoperative data, and postoperative data within 30 days of surgery. We stratified our patients into open and robotic surgery. This was all non-parametric data, just given the small volume that we do have of these patient populations. And we compared our groups using Mann-Whitney U-test and Fisher exact test. So over 6 years, we enrolled 111 patients. 95 of these were done in the open procedure and 16 were performed robotically. And what we found is that for demographics, there were really no differences between the groups with the exception of median income. Not really sure what that says about our groups or how we select them, but median income was significantly higher in the robotic group. However, the ethnicity and race were the same between the two groups. Age was the same, even distribution of males to females. Insurance was the same, comorbidities were the same, ASA score was the same, BMI was the same, and most importantly, the primary cancer was the same. There was no significant differences between open or robotic. Also, most importantly, the PCI was no different between the two groups, and these are median PCIs of 12 and 10 for these operations. However, the EBL was significantly lower in our robotic group, at 400 for the median for the open and 113 for the robotic. Intraoperative time was not significantly extended either, and that's important because you don't want to keep these patients on the table for a long amount of time. And part of the criteria of our selection is, can we complete this robotically in the same amount of time that we can do it open? Now, on postoperative analysis, we actually had fewer blood transfusions in the robotic group. And this is pretty significant because, again, there's a dose-dependent response to transfusions and poor oncologic outcomes for patients with peritoneal surface malignancy. We also showed fewer minor complications. I know it says 0. This is median, again, not average. And then we also showed a decreased length of stay from 9 days to 5.5 as a median time, with no difference in 30-day mortality. This is generally our setup for the robotic HIPEC. The 1A tab is our most common setup, with 2 trocars placed on the patient's left side, one at the umbilicus and one on the right. And we have 2 assist ports, one above and below the umbilicus. Occasionally, we'll adjust the ports depending on where the disease burden is, either in the 2A configuration for right lower quadrant tumors, or in the 3A if we need a second hand on the patient's right side. And for the HIPEC portion, this is what it looks like intraoperatively. The Y connector is the outflow loop that's usually placed above the liver. The single inflow port is placed on the patient's left side and into the pelvis. And then the 2 wires are the temperature sensors that monitor where our temperature is of our HIPEC. So limitations and future directions. This is a retrospective single center, single surgeon data. So there is a lot of bias that's injected into this data. And we really need longer term follow-up to ensure that the oncologic outcomes do pan out for disease-free survival and overall survival. So in conclusion, robotic HIPEC for our data is equivalent for demographic, again with that exception of median income, intraoperative and immediate postoperative measures when compared to open cytoreduction HIPEC for highly selected patients. Robotic cytoreduction HIPEC did display a statistically significant decreased EBL, transfusions, and length of stay. Thank you.